Hello, everyone. Welcome to the Canadian Bioethics Society's conversation series, Conversations in Canadian Bioethics. My name is Angel Petra-Pranagos. I'm a practicing healthcare ethicist in Ontario and the communications officer for the Canadian Bioethics Society. I really want to give a warm welcome to everybody joining us today, including our Canadian Bioethics Society members, supporting organizations, and maybe those of you who aren't yet members of the CBS, but who are interested in joining or enjoying these conversation series as well. So thank you for coming. Our topic today is racism in medicine and medical education. So in today's conversation series, there are lots of ways to join the conversation. So we're very pleased to have live simultaneous interpretation available for the series in both French and English. And I see Andrew's just added how to become a member for the CBS in the link. So check it out if you're not already a member. And a reminder that the conversation today is being recorded as well. So in participating in the conversation, you can do interpretation. And you can, to hear everything in a particular language of your choice, whether it's English or French, you can go to your Zoom toolbar and click on the interpretation icon, and you'll find that option there. We also have closed captioning, and as the speeches and conversation is going, you can read and close captioning. And if you go to the More tab again on your Zoom toolbar, you'll find the closed captioning option. And so we'll be holding a discussion period at the end of and throughout the session. And so you're welcome to type your questions as we go through the conversation using the Zoom Q&A function. And that'll be probably at the Zoom toolbar at the bottom or top of your screen. And we want to encourage you to ask the question in whichever language you feel most comfortable in. So you can ask in English or in French, and we'll have those questions translated and interpreted for us in the discussion as well. And just a reminder, if you have any feedback about today's session or ideas for future sessions, we'd love to hear from you. Feel free to reach out to the CBS. And so now, last but certainly not least, it's my pleasure to introduce our speakers and moderators for today's session. Our first speaker is Dr. Naila Ramji. She's a maternal fetal medicine specialist at the Everett Chalmers Regional Hospital in Fredericton, New Brunswick, and also an assistant professor in obstetrics and gynecology at Dalhousie University, with cross appointments to the Department of Bioethics. She's involved with both clinical and bioethics research, ranging from the impact of maternal obesity on stillbirth to the bioethics of translating limited evidence into clinical practice and difficult decision-making and uncertainty in high-risk pregnancies. She's a member of the Dalhousie Medicine New Brunswick Research Council. Apart from her involvement with teaching and mentoring medical trainees in research and in the clinical setting, Dr. Ramji serves as the advisory board for the Department of Bioethics at Columbia University and continues to guest lecture at Columbia. Her published research and clinical opinions have been featured in the popular press, including the Global National News, Today's Parent, Medscape Medical News, and the Ottawa Citizen. Welcome, Dr. Ramji. And our next speaker is Dr. Gaynor Watson-Creed. She's Associate Dean of Serving and Engaging Society for Dalhousie University's Faculty of Medicine, and also an assistant professor in the Department of Community Health and Epidemiology. She's a public health specialist physician with 18 years of experience, having served as the former medical officer of health for the Halifax area and deputy chief medical officer of health for Nova Scotia. Dr. Watson-Creed has an MD from Dalhousie University, a master's in science from the University of Guelph, bachelor of science from the University of Prince Edward Island, and honorary doctorates from Acadia University and the University of Prince Edward Island. She also sits as chair or member of several national population health councils and boards, and was appointed to CIHR's advisory board for the Institute of Population and Public Health in 2023. Dr. Watson-Creed is a passionate advocate for high-quality public health services and for anti-oppressive healthcare in Canada. Welcome, Dr. Watson-Creed. And last but not least, our moderator for today is Dr. Lynette Reid. Dr. Reid is an associate professor in the Department of Bioethics in the Faculty of Medicine at Dalhousie University. Dr. Reid's work is at the intersection of public health, clinical ethics in primary care, and social and political philosophy of health systems. Recent publications include an analysis of the distributional nature of population health and a discussion of the implications of Piketty and colleagues' work on economic inequality for bioethics and health equity. Her current projects lie in two distinct areas. One involves questions in ethics and in philosophy of medicine that arise in the current cancer screening controversies. The other involves normative and empirical challenges to systems of universal health coverage. She's currently involved in projects implementing anti-oppressive frameworks in medical education. So welcome everyone to our speakers and our moderator. Thank you so much for being with us today and leading this discussion. And we'll turn it over to Dr. Reid.
Thanks, Angel. Thanks so much to the CBS for inviting us to give this presentation and to do it in this conversational style. I'll be asking Gaynor and Naila some questions, and we'll be inviting you to join in and add your questions to the conversation. I'll start with the land acknowledgement. We handed it over to me. The three of us speakers are coming from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq and Wolastoqey people, here on the east coast of what the colonizers call Canada. We also acknowledge in our context the contributions of 400 years of persons of African descent in the Atlantic provinces, and also the little known fact, I think maybe it's not paralleled in the rest of the country, of unsettled land rights and land claims of people who were invited here 400 years ago by the British government and never properly given title to their land, but who have made a strong contribution to our communities over centuries. So now I invite you to think of the meaning of land acknowledgements for yourselves in all of your contexts across the country, across the region, and across Turtle Island. I think the title of our panel includes so much: racism in medicine and in medical education. So I'd like to invite each of the panelists to reflect on, to share with the audience what each of you are doing in anti-racism in medical education and medical practice. How did you get involved? Where do you find it's taking you? Whoever wants to jump in first.
Go ahead, Gaynor. I'll go after you.
Yes, I would start by saying, so you heard from my bio that my title is a strange one, maybe for Faculty of Medicine. It's called Associate Dean for Serving and Engaging Society. And here at Dalhousie University, that includes what has become our anti-oppression portfolio in the Faculty of Medicine. So this is our anti-racism work, but also our work to tackle sexism, misogyny, homophobia, Islamophobia, ageism, ableism. All of those forms of oppression fall into the definition of what it is that we're trying to look at. And so that is my current day job, but not a stretch from where I have been in my career. I grew up in a sociology household. My dad was a sociologist. His area of study was the Black diaspora, and sort of the story of the Black diaspora around the world. And so conversations about inequities and about oppression and about social systems of power, that was dinner table conversation for my sister and I growing up. And so it's probably not a surprise to anybody that from there, when I chose the medical specialty, I chose public health as the specialty that deals with social and structural determinants of health and health inequities. And so I'm not surprised to be doing this work necessarily now, except to say that, in the fits and starts I had at directly anti-racism work before this current post, there was always the challenge of trying to do the work as a racialized woman myself. I started in earnest doing that in some ways as a university student. That carried on when I myself was a medical student here at Dalhousie. I got asked to do a project on anti-racism for the Faculty of Medicine all the way back then. My 25-year reunion is this weekend, actually. So wow. Even then I was doing that work, but recognized the toil of it. And so, but if I'm surprised by anything, it's that I'm dedicated to doing the work now, having had that big, wide journey along the way of getting here.
I Yes, my work has always been more towards looking at women's health and focusing on discrimination at the level of the healthcare system or at the level of communities where women are, and their health and their lives are affected most. But I have found that in medical training, I've been more and more exposed to issues of oppression with vulnerable populations. So that includes new immigrant and refugee populations, especially where there's language barriers. I did my undergrad medical training at McGill. And so I had the opportunity to volunteer with organizations that worked with the new immigrant and refugee community, and could see all the ways in which these populations had to struggle with language barriers, access to information, not knowing how to navigate the system. And then seeing that kind of permeate all the way through different levels of medical training and noting different levels of awareness of those issues depending on when I was training in a big city versus when I did my residency in Newfoundland and now working in Fredericton, and seeing how that is, there's a bit of variation, but a lot of the similar themes kind of come up for these populations all the time. Also in my work with Indigenous populations in medical training, I think you get exposed to a lot of those different cultural issues, and seeing the doubt and the skepticism from the communities that have been oppressed in the past, and so are rightfully more skeptical and suspicious of the institutions through which medicine operates. And so trying to navigate that has always been a challenge, and trying to bring that lens of compassion and advocacy and understanding to the work is always part of it. And then you know, I have also surprisingly, because I was surprised, endured some, you know, moments in my medical training. You know, when I was a medical student, I walked into the room and an elderly patient, otherwise very lovely woman, said, "How now, brown cow?" And, you know, just sort of these random comments, these little kind of subtle, that was less subtle, but these little sort of subtle digs that you don't expect when you're walking into a room and your goal is just to take care of this person who's sick, and then to find that this is brought up in the interaction. So I think sometimes, you know, that can catch people off guard. And over the course of many years, you talk to other visible minority physicians or clinicians, and you hear similar stories of, you know, where it's difficult to navigate when patients treat their care providers that way, or when care providers treat other care providers that way. So there are many different dimensions to which this kind of comes up in medical practice.
I wonder if we could, I think I'll do a little trip down memory lane to where the three of us convened in a panel that was maybe or in a talk. I think the two of you were on the panel, where that led to this idea of doing the session for the CBS. It was when Dalhousie had Harriet Washington here about this time last year to talk about her books, including her book, Medical Apartheid. Now, this book, Medical Apartheid, in the audience, if you don't know this, it's not a book about South Africa. It's a book about the medical profession in the Americas, in North America, and a lot about the United States. But the juxtaposition of these terms is pretty striking. I wonder if you could comment on the history of the relationship of medicine to slavery and to racism and racial hierarchies.
I'm going to give you
I know
first.
either of you can go
Okay.
on about this.
Fair enough.
It could be very informative. Like
Sure. Well,
first. Okay.
I mean, as an obstetrician, I think the examples that really stand out are the examples of Marion Sims, who is, by the old-fashioned way, considered, quote unquote, one of the fathers of obstetrical medicine. And he was a slave owner, and he abused his slaves, and he conducted medical experiments on them without their consent. Without analgesia, he would cut his female slaves' vaginas to study fistulas and what is the best way to repair these traumatic injuries after birth. And he would cut them and then try to repair them. And they were given nothing for pain. There was no consent. And I think this is really an example of, you know, that kind of oppression that took place in that time. And so that was an example that Dr. Washington talked about and has talked about with me before when I was her student at Columbia as well. And it's certainly one that just really is, it's a very vivid image and it's very striking. And these are, you know, someone like Marion Sims is like revered in medicine in the past anyways, and you don't hear these stories and you don't hear about these really criminal behaviors.
Yeah, I mean, I would echo that, and of course, Marion Sims is but one example of many. In fact, physicians who were the architects of what is now known as race science, the idea that skin color confers something that is biologically different between white populations and non-white populations, and this is an idea that has persisted in medicine until modern times, until today. And so a couple of things come to mind for me in that. One is that the naming of Dr. Washington's book, Medical Apartheid, I think it speaks well to the idea that there is a system of medicine which white providers and white patients might enjoy. And in South Africa, as in other parts of the world, there is a very different system of medicine that has been applied to non-white populations, particularly during colonial times and during the transatlantic slave trade. And so one of the things that I like to point out to folks when I talk about the history, for example, of J. Marion Sims, is that not only was he a slave owner, but some of the reason he did that research was that economically, it was seen politically, it was seen as an imperative to understand in what ways slave owners might be able to propagate their own slave populations at a time when the transatlantic slave trade was about to end. Slavery had been banned in the UK, and so the end of the slave trade was considered to be near. And so some of what Dr. Sims and his colleagues were looking for were ways to unlock reproductive access to more slaves. And so it wasn't sort of, if I can put it this way, benign scientific curiosity that drove some of his exploration. There was also an economic imperative at play. Those are some of the entanglements that the medical profession has had with slavery and with the abuses of slavery and colonization that we don't often talk about, to Naila's point. And so that for me is an important part of the link to what Dr. Washington was pointing out to us.
Mm-hmm. I'd like to maybe invite a little audience participation and conversation. So the next question I'm going to ask the panelists is a question everyone can answer, and it'll help us all see if we're all on the same page, if there's things you would like us, the audience, you'd like the panel to address that we might or might not have planned to address. So if you take this question, what does racism in medicine and medical education mean to you? What are its different forms and manifestations? And let's just brainstorm for a moment. So people in the audience, please put this in the Q&A and it will be passed on to us in the chat, and I'll be able to bring your comments into the conversation. And Naila and Gaynor, as we're waiting for thoughts to come through from the audience, why don't you start us off and each name a couple of ways that racism manifests itself in medicine, medical education, medical practice, and science.
Yeah, I think there's the personal, interpersonal, clinical interactions in which you see things manifest, and then there's the bigger systemic level. And as a clinical researcher, you see it manifest in research as well, which is a big part of medicine and medical education. So I think it's very interesting that over the years, we've been seeing more and more awareness around the problems of racialized medicine in research. And there was recently an editorial published in the American Journal of Obstetrics and Gynecology that actually is is entitled Racism as a Modifiable Risk Factor for Adverse Pregnancy Outcomes. And essentially it argues that traditionally race has been seen as a non-modifiable risk factor for certain outcomes in health in general, but in pregnancy in particular. And that really we should be looking at racism as a modifiable risk factor. So see where those systemic changes over time can be made, and whether that's actually what can improve outcomes, is not looking at race as something that, oh, well, too bad you're in an unfortunate race category, but recognizing that it's really about those populations with those adverse outcomes. It's because of racism that they are experiencing those, not because there's some innate genetic problem. I mean, there are some conditions that we see in gynecology, for example, conditions like benign fibroids to a greater extent affect Black women. And I think it's very interesting when you look at the science and in different areas of medicine, like the extent of research and the extent of looking into, like, this is something that severely affects people's quality of life. Why is there not more research looking into this? Why is, we do have some basic treatments, but it's not addressed as an emergency in the same way that other health issues are. And I don't think that that's by accident, because when you look at which populations are more affected by one condition or another condition, and the seriousness with which those conditions are investigated and made a priority, I think that is a little bit of a concern. So that would be one example. And then at the level of the clinical day-to-day interactions, I think I spoke before about vulnerable populations, marginalized populations like immigrants and refugees. And we actually see this discrimination play out in the medical context, in which we have to use language lines to translate. And sometimes when clinicians are trying to explain something to their patients that they don't understand, either a diagnosis or a course of management, we do it in so many different ways to ensure that the patients really understand. We might draw pictures, we might explain it this way, we can get that they don't really get it, and then we find another way to explain it. And because using a language line can be so cumbersome, can be difficult to reach them, takes so long to go through a third party, oftentimes you'll see less effort put into all those many different ways of explaining and making sure that you're well understood, and it takes time. And so that's something that at the individual level happens, but it's also at a systems level where there isn't enough time to do that properly with patients. The system doesn't allow for that. And then these patients are also trying to navigate systems where they don't understand how it works, where clinicians need to be aware of what services are covered by the interim health refugee program versus not, to be able to guide patients so that they're not being charged for things they shouldn't be charged for, and that it requires more literacy on our parts. And I think that that's true of many different areas. So I can go on, but I'm going to let Gaynor contribute her part.
We both could, because this is where we connected, I think, on the panel last year as well, in terms of all the ways that racism manifests in the healthcare system. And so I would, on a systems front, I would go even further to say, we now have around the world professional bodies, colleges, for example, registration colleges for physicians, now looking at which groups of physicians are most likely to get the highest volume of complaints against them, and recognizing that in many circumstances, it is racialized physicians and newcomer physicians in particular who are at the highest threat from the public and from the profession as well. And so those are some of the other systemic ways that we start to see racism manifesting. From a medical education standpoint, we're recognizing, and Lynette, you and I have long been in this project, recognizing the ways in which the pedagogies that we use in medical education uphold quite well forms of racism in medical education. The ways in which we only refer in clinical case presentations to patients if they are racialized, suggesting that race is something that cues you to pathology but doesn't cue you to anything else meaningful about those patient identities. But we conveniently always leave the descriptor, the modifier, white, out of patient populations, as though that should be accepted as the quote unquote norm, right? And so that act of omission, normalizing whiteness as something that we shouldn't even question. We use the term Caucasian in medical education all the time without recognizing that the social scientists have been telling us now for several decades that that is a very racist term that has very racist origins around white supremacy, which we have failed to recognize as a profession as damaging. Even things as maybe seemingly benign as our continued use of the 70-kilogram man as the reference human. For those of you who don't know the story of the 70-kilogram man, this is a description that was put forward for scientists as they constructed clinical trials in the 1970s by the International Association of Radiologic Classification. They were trying to define a reference human. They literally say that in the original document, the reference human could be considered to be a 70-kilogram man of European descent. Now, for most of us in clinical practice, our patient population by no means is served by a 70-kilogram white man who, by the way, is probably also cis, hetero, and able-bodied. That is not the patient population that we are seeing. And so there's a way in which that reference human doesn't work on any level, but you continue to hear clinicians teach that to students. The idea being, if you understand pathophysiology in a 70-kilogram man, then you understand it in everybody. And my colleagues like Naila in obstetrics and gynecology will go, that clearly doesn't work for the populations that I work with. The pediatricians will say the same thing. But this ridiculous idea persists in medical education. And so there were things like that we're starting to uncover, but that really demonstrate how much we have been perpetrating forms of racism, even there.
And I think I just wanted to quickly add that, you know, the Indigenous population is exposed to much higher rates of toxins. We have a lot of data that show this. There are First Nations communities in Ontario that have 44 times higher than what is considered safe cancer-causing chemicals in the air. There's a lot of subsistence fishing and all that stuff in a lot of the Indigenous communities further up north as well that exposes them to higher levels of toxins. And there's very little in our medical education and in our medical practice that leads us to look at that, to look at environmental toxin exposure as something that we ask about, to even study, to even measure like blood levels or anything like that. Like, this is not something that is routinely done. It's still all considered research. And there's very little that we know of in terms of interventions, treatments. It's just something that hasn't been prioritized, and there are vulnerable populations and racialized communities that are more likely to be exposed to these. So just because I know that we had our land acknowledgement before, I just wanted to make sure I acknowledged that very important bias in our medical practice.
You did that last year. I sat at the Canadian Public Health Association talking about environmental racism, which is another way in which racism manifests in Nova Scotia, in the African Nova Scotian communities as well. This has been an area of concern. There was a last year provincial panel looking particularly at environmental racism. And again, what's fascinating to me, what I sort of disclosed to the CPHA panel was that even our best public and population health science doesn't account for the ways in which structural racism may drive our inability to look at what communities are telling us they know they're exposed to. And so I described during that panel the ways in which I was brought concerns of environmental racism from communities in Nova Scotia several years ago as a medical officer of health, and did not have the scientific tools to be able to. I had scientific tools. It's just that when I went through the tools, what they told me was there couldn't possibly be a problem here, which is what I said to community. And so I'm now questioning the validity of those scientific tools with all that we know about environmental racism today. So you're quite right to point to that in clinical practice, and I would say even in public and population health, where we espouse the values of wanting to, expose health inequities for the purposes of resolving them, we're not doing a great job.
Mm-hmm. I want to bring in some thoughts from the audience here. They're all sort of meshing nicely with what you're talking about. We have a two-word contribution. Epistemic racism was the first thought out the door from our participants of different forms that racism takes. So I thought, Gaynor, you've just been almost alluding to this. So maybe you could say a little bit about ways in which, you know, what we take seriously as knowledge, who we take seriously as knowers, how that manifests racism in medicine.
Yeah, that idea of how how our being interacts with other beings in the world, and how we view other beings in the world in relation to us, is a really important one in this. And what I always remind audiences of, for example, when I'm giving grand rounds presentations on anti-oppressive practice, is that one of the challenges we have in medicine in particular is our own ontological arrogance. So we believe that our way of being is quite fine, thank you very much, and that our way of knowing is equally fine. And if other people knew what we knew and were like us, then they would be fine too, without having the humility to say, perhaps our way of seeing the world is not complete, and we could benefit from having the gaps filled in by others. Just as an example, I will regularly use as the lead off to a talk on anti-oppression, a beautiful paper that was written by a female journalist exploring the perspective of a female ornithologist in her research on duck genitalia, of all things. But what I love about the paper was that this ornithologist was very clear about saying she's working with an all-male team who was only focused on duck penises. Yes, they do have them. Until she pointed out that there needed to be a recipient organ in female ducks, and nobody had gone looking for it up until that point, right? And that's where her way of seeing the world, her identity in the world, really mattered to the advancement of that research and to the advancement of questions that were not being asked up until that point. And so when I talk about the incompleteness of our own, sort of understandings of our being and our forms of knowledge, that's the risk of staying in that incomplete state, is that we miss so much that could be added to our understanding.
Mm-hmm.
Mhm.
The next contribution from the audience actually flows nicely, because now it's talking about in the individual physician-patient relationship biases and prescriber. I guess we're in a world where people are prescribing beyond physicians, so I shouldn't avert to that language. So physicians, pharmacists, others who are prescribing may be less inclined to prescribe pain medications to certain populations. So biases in prescribing practices. Naila, I thought you might be able to speak to this from your context.
Ouais, puis j'ai vu que la question était
Yes, and I
originellement.
also saw that the question was asked in French, so I will answer in French. That is the truth. We see it frequently. In fact, there was a case of a famous athlete. It was all over YouTube, and I think it was a football star, and he had a muscular problem or a fracture, and he went to a hospital and he videoed physicians and nurses who said, I'm sorry, I was reading a pop-up. The physician and nurses were saying, you're just trying to get medication you have no need for, you're just looking for drugs, things like that. And this is a very famous African American. So we see it a lot. And when I was a student in McGill, in Montreal, we had a relationship with a patient. We were trying to better understand their experience over the course of many months. And this was a patient who had sickle cell anemia. And this was a person who was in throbbing pain and needed very potent medication. And he said, every time I go to the hospital, they tell me that I'm just looking for drugs because I'm Black. And that's the reason. So that really is a problem. It's it's a problem that we see frequently, and this is something that has was the case back in Marion Sims' time. She said, I don't need to give the woman medication if I cut her vagina because she'll be fine. It's the same stereotype, and there are many physicians who think in the past, really, they think that people of African descent don't feel pain the same way, which is obviously not the case. And reality is that it causes a lot of problems and difficulties for patients who cannot access the medication they need.
Sorry, my French is imperfect. I tried my best.
Thanks. We have a question. Yeah, Gaynor?
Oh, no, I was just going to add that notion that Black patients in particular don't feel pain is a very real one, and emblematic of the scientific racism that was propagated in the 1700s. That particular diagnosis comes from Samuel Cartwright, who was another American physician practicing in Louisiana at the time. And he actually put forward a diagnosis for that condition. He called it dysesthesia ethiopica, the idea that Black people don't experience pain, which was the justification for not offering anesthetic. It was picked up by other physicians. Again, there was an economic imperative as well. Anesthesia at that time was actually quite expensive in the United States as well. And there was somewhat of a shortage. And so just important to recognize that that was the context. In 2017 or 2018, an American study surveyed attitudes of incoming medical students in that year to Black patients in pain. And even then, 47% of the study population believe that Black people don't experience pain to the same degree as white people. So it's not just a historical construct. In real time, it plays out in a number of different communities. I have heard this, for example, from nurses who will swear up and down to me that people with dark skin have thicker skin, and therefore that's the reason that they don't feel pain, et cetera, et cetera. The consequence is that any of us who wear racialized identities know that that becomes part of the story about our identity when we walk into an environment. And so for the folks who are deeply harmed by that, Joyce Echaquan as an example, the many Black people who have died at the hands of police, for example, what they understand is that they have to be very careful about how they are perceived when they go into any environment, because their notion of their identities, no matter how dearly they hold those, will change depending on who is interpreting those identities when they walk into the environment. And in some cases, the interpretation can be life-threatening. And so that's part of what contributes to this idea, for example, this phenomenon of racialized patients not receiving pain medication.
Yeah, thank you for those reflections. I'm going to skip around a little in the questions too. I'm going to come back to everybody's questions, don't worry, and contributions, but skip around a little bit to draw the thread along. There's a reference to many, to trainees and people learning and practicing medicine having access to, not having access to portrayals of dermatological conditions and different skin colors. And I'll just preface our conversation around this with letting you know that Gaynor and I worked together on a project here at Dalhousie Medical School that was, we called it case diversification. It was way more than that. We had a committee, a group of about 20 faculty, staff, and students, and a full-time case writer, equity, diversity, inclusion, case reviewer, support, to go over the 200 CBL cases that are used across the curriculum, and that are the bulk of the pre-clerkship curriculum. So students attend tutorials and discuss these 200 cases. And we were diversifying the patients. So we were breaking down the assumption that if it's not stated, they're a white middle-class male who is cisgender and heterosexual. So state everybody's identities, make those identities more diverse, intersectionally more diverse, bring out the relevance of the identity for their medical condition and for how it's treated and for what their experience of the healthcare system is, for example. And we found we couldn't do that unless we also examined the science in the cases, because you can't just, diversify your patients and then continue to treat them based on racist science, and science that is wedded to a sex gender binary that's unrealistic. So the project became quite large in terms of really engaging across faculty with case authors, curriculum leaders, discussions about race and about social identities. So I have to say, as a sort of naive white person doing this work, I was astonished the extent to which the cases repeated to students over and over again for 2 years as they begin medicine, that race is real, it's biological, and it's the cause of many differences, race, not racism. And the extent to which just fundamental assumptions about whiteness shape the materials. So dermatology is one piece of it. And I mean, we all know how old we are. We all know how long ago the civil rights movement happened. But medicine until now teaches with materials that are only changing in the last 2 or 3 years that predominantly present white skin to students. And that's dermatology, but it's also any clinical condition for which a manifestation on the skin matters, which can be cancer, it can be rheumatology, it can be anything really. And as we were working through the cases and revising them, we went looking for images, and there are still many conditions for which you cannot find images on non-white skin, despite many more diverse medical students now starting projects to share these images on TikTok, to share them on Instagram and so on. And this has just been sort of astonishing to me. I mean, I feel naive that I didn't know this was happening. But maybe we could talk about some of those ways in which that long history of racist science, of medical science being designed to prove certain things about Black bodies with an economic incentive for slaveholders, trainees are still learning them today, and medicine is still being practiced that way today.
And it is changing. And so I just want to acknowledge a couple of things. You will have heard Naila and I both, I think, make reference to anti-Black racism and anti-Indigenous racism specifically in that conversation. That's not to say that other forms of racism don't exist, but in those two cases, there was a huge economic driver behind the practices that was colonization, and the transatlantic slave trade is part of that. And so that gives those two populations, an unfortunately deep level of impact experienced from those events and disadvantage experienced from those events. So I just want to put that out there in case folks are wondering, why are we spending a lot of time talking about anti-Black and anti-Indigenous racism? It's because they were the drivers behind many of the ideas that we're stuck with today. But they are changing. So I'm reminded of the atlas that Chidiebere Ibe, who was a Nigerian medical student, put forward, I think in 2020 or 2021. And Naila, you may remember this. It went viral on social media because he dared to put forward an anatomical cross-section of a pregnant woman who was Black with a Black fetus. And the commentary around that was, this is preposterous. Everybody knows that babies are born white. Like it was hugely controversial. And he did it precisely because he recognized that there was a need actually to portray something other than white bodies in, gross anatomy atlases. And it had not been done before, right? But now those images are becoming relatively commonplace. Medical students know where to find them. They're challenging their professors to update their materials. So that's happening too. Similarly, we have Andrea Dayrup, who is a pathologist at Duke University, who last year published as a co-editor the 11th edition of Robbins Pathology, where she agreed to take on that project on the condition that she could go through the 10th edition and remove all of the inappropriate race-based medicine references that had been there before. So for those of you who are looking for your next sabbatical project, you could take on a textbook, the textbook of your choice, and think to edit it in that anti-oppression kind of way that Dr. Dayrup took on. So those opportunities are there, and some things are changing slowly, but we are moving ahead, which is nice to see. And the diversification project was one great example of that, as much of a slog as it was at times, Lynette.
It was a lot of work. I mean, I recall my own experience of going through case after case where data that was really collected in the United States with racialized identities attached, in order to, I mean, the intention behind the tracking of that data is to highlight disparities caused by racism. As Naila says, racism is a modifiable risk factor. Race is people's reality, and it has very little to do with their health status, actually, if we believe modern genetics. So but just that constant repetition in every single case about these risk factor differentials and how that seeps under people's skins. And this ties back to something you talked about, Gaynor, earlier, about the epistemic tools to pull apart environmental racism. Because part of what's happened is these social science critiques that many of us, if we're here as ethicists, we know from our humanities and social science training, these have worked their way into medicine now, and people are doing the science behind uncovering and picking apart those biases. And one big piece of it is that what they used to do, all these studies, you could come back with 100 studies for any given clinical condition that says, no, it is biological, it's not social, because they controlled for education, they controlled for income, and they said if there are remaining disparities between the races, it must be biological. But what there are now are tools to control for environmental exposures, tools to control for childhood diet, tools to control for a much more robust picture of the social determinants of health. And when people do that, then all of this supposed scientific truth that there really are biological differences falls apart. So these threads all tie together, and it is really, I find, as an ethicist, speaking as an ethicist who had my humanities and social science training a long time ago, I've watched these conversations about race. It's such an exciting time in medicine that people have taken on board the critiques of social scientists and historians and ethicists, and are finding out that those critiques might have come from a very different tradition of thought. They weren't, they don't arise out of rigorous clinical trial design, which has been how people learned science in the past. As you try, if you make a rigorous clinical trial, then it's scientific. But that deeper critique of scientific frameworks is really coming through now. And we had other social scientists involved in the project. You've referenced the sort of normative, like white 70-kilogram male. There's a comment here about racism in medicine manifest in how it, for newcomers who are often racialized, but they may also be newcomers from white European nations or backgrounds, physicians are often approaching them with a kind of an idea in mind about disease prevalence in different populations, and that creates biases and diagnoses. So why is this happening, or diagnoses and explanations for the clinical condition? So that's a really deep, I can totally see that as a non-physician going through the medical curriculum, as it were, over their first 2 years. So it was like, oh, I'm being trained to think if I see someone who looks like this, they must have this. Could you comment on this?
Yeah, I think a really important aspect when you look at that is, rather than looking at what country they come from or what color their skin is, refugees in particular, but also a lot of new immigrants, depending on whether they're new immigrants, but they're coming from a war-torn country or how hard it was to get here, a lot of them have trauma. And really the focus should be trauma-informed care and awareness of the role that trauma plays in shaping their health, more than where they're from or what they look like or all those other things. Because, for example, you might have a clinician see someone from a certain cultural background. The husband seems very overbearing, very controlling. They suspect that, oh, it's in this cultural community, there's probably abuse, or he probably does something to his wife at home, or who knows, right? But we know that people who have endured violence and endured trauma are more likely to perpetuate that. And that can be why that is being perpetuated, not just because, well, they must come from this community that beats their wives, right? So I think there's also a little bit of this lack of attention to the role of trauma, and then also the othering of these behaviors that we actually see commonly across populations, across socioeconomic status, across education level, and when you look at intimate partner violence and abuse, right? Like there's evidence that happens. Like people to this day think that it happens more to lower socioeconomic and lower education people, but it happens to everybody. So I think it's very interesting, you know, when you look at that, like how is that affecting diagnoses and treatments? The other aspect is the language barriers. And like I alluded to before, how much time are you taking with the language, with the translators? How much time does the system allow you to take with patients that need more time? Because that's where those details get elucidated or not. And sometimes a word in one culture or one language means something slightly different in another culture or another language, and you can miss a lot in that. And a very one example is like, you know, in English, when we want to say two, we'll say a couple. There was a couple of this. And in French, we'll say un couple. Un couple in French doesn't mean two. It means a few. So like, this is something that in Canada, as English and French, we all think we really understand couple, couple. Obviously, it's the same thing, and it's not, right? So if you don't understand even at this very basic level of regular words that we use all the time, like there are so much nuance and complexity can be lost in translation. So that's really our job as a system and as a community of providers to just do a better job of trying to get to the root of what the real problems are. And sometimes in certain cultures, people come with a certain complaint, but they have they have that door handle diagnosis we used to learn in medical school, where you find out what the real problem is when they're about to leave, right? So it's about having the time and the space to be able to ask those more probing questions.
Yeah, well said. I mean, the other thing I would add to the notion of trauma-informed care, which I think is exactly the place to go, is to remember that trauma does not necessarily have to be temporally recent either. So to the extent that folks come from a community that has been repeatedly traumatized over generations, like Indigenous communities, like communities within the Black diaspora, some of the behaviors attendant with managing your trauma may get passed on to subsequent generations, and that may show up in the interaction in a way that is misinterpreted for all the reasons that Naila spoke to. So it's a very, very complex landscape, but absolutely right to point out that it persists, which is why we need to take on board some of the strategies that Naila laid out.
We also just had success in the last couple of years of the Medical Council of Canada, who sets the standards for the qualifying exam across the country to revise their objectives, so that their objectives for anti-oppressive practice, newcomer health, and what they used to call special populations no longer say special populations have unusual diseases, name and list them, and list the cultural practices that they might be using to manage these diseases. So we changed that. That's no longer, but that was up until 2 years ago, a kind of objective for the qualifying exam. So it's not surprising if physicians would be stereotyping newcomers in terms of, and having clinical biases in terms of what conditions they expect them to manifest as newcomers to the country. A lot of change to happen all over. So there's a couple of questions I want to tie together here, contributions from the audience that relate to something Gaynor alluded to in her initial comments. And this is about how standards of civility and professionalism in medicine can actually become ways of excluding people from the profession, keeping people out of the profession, being barriers to advancement for medical trainees and professionals who may be IMGs, people who qualified as physicians elsewhere and are now requalifying in Canada, or students of racialized minority groups, racialized groups in Canada, global majority racialized minority within Canada. So I think this is also something really interesting to look at. People are really looking for, in the comments, for some concrete help to think about how to move those conversations forward in their own institutions. I think many people involved in ethics might be the people who are involved in those conversations around professionalism with trainees, and be seeing that, have those questions arising for them. Do we have a notion of professionalism that's being used to keep people out of the profession, as a matter of fact?
Yeah, happy to jump in on that, and I'd really appreciate your thoughts on this as well. I mean, a few years ago wrote a paper in CMAJ on institutional betrayal in academic medicine and what it looks like, and it very much looks like what you and what the folks who posed the question are portraying. This idea that we may espouse values of wanting to be anti-racist, anti-oppressive in practice, but then in reality, we will use the tools of the profession to actually continue to oppress different groups. And so that's a very real phenomenon. And I continue to get stories from across North America from colleagues who are experiencing that exact thing. And so the notion of anti-oppressive practice is the idea that the practice is grounded in understanding what are the identities of the people involved, which of those identities confer power and privilege, and which confer disadvantage or at least less power. And how is that then playing out in the scenario at play? And so sometimes when, for example, a professionalism complaint comes forward through, for example, our professionalism committee at Dalhousie, if I'm asked to give an opinion, what I'll often say is, look at the identities at play. Who is the underpowered identity here? Run the scenario from their perspective a few times. And at the end of that, are you sure that they are not actually, regardless of whether or not they submitted the complaint or were the subject of the complaint, are they at higher or lower professional risk here from the outcome of this than the other person? And I always suggest that we pay attention to the underpowered person in the dynamic, because they often have, in fact, the most to lose, and they know it. And so they're not likely to bring forward, for example, something, a complaint of sexism, racism, whatever it is, frivolously, but often the institution will come back at them with, your complaint itself is unprofessional, unethical, whatever the excuses are that have us not actually look at the complaint for what it is. And so those are some of the ways in which those terms, professionalism, patient safety, ethical practice, can get used against minoritized groups in an academic medicine setting. And it's incumbent on us, I think, who are in those conversations about the power dynamics, to really be careful about how we examine which dynamics are at play, which identities are at play, and their voice is strongest. And it may not be the way that you thought it was going to be when you first looked at it, right? So you may hear a complaint from a group that looks like, of course, this must be a valid complaint against a racialized professor. And by the time you've done that analysis a few times, you go, wait a minute, even though that person has the identity of professor and therefore might be higher in the totem pole, so to speak, actually, they've got all kinds of other identities that put them at highest risk here. And maybe we should examine this complaint again from that perspective. It's very, very tricky work. But if we're not looking at identities, we're not actually doing identities and power, then we're not actually doing anti-oppression work. I don't know if that makes sense to you, Naila, in what you've seen.
It rings very true. Even in the, for example, the College of Physicians and Surgeons of New Brunswick, there are more college complaints launched against physicians who are a visible minority or physicians of color. I mean, to some extent, I think even that terminology is derogatory, right? But yeah, like, and these complaints are launched as legitimate complaints or issues, and it's challenging to parse it out in terms of what is a legitimate issue and what is just targeting someone who's different. And so I think that's, I mean, you see that in different settings, right? Whether you're seeing it through the university at Dal, or whether you're seeing it through the College of Physicians and Surgeons, which is a regulatory body that controls physician licensing. You know, so that's really important. And then I think, and this might speak to, I think I saw one of the questions in there about professionalism from the perspective of medical trainees who are being targeted by, you know, racialized comments or these sorts of things, and how it can actually interfere with their training and their education. And I think it's important to acknowledge another aspect of professionalism, which is that you might have a resident, you might have a medical student who is targeted by a patient or by a colleague, and other people, the bystanders, the other doctors, the attendings who might witness it or who may not know about it, like there isn't recourse for these individuals. And it is deemed as like there's still this attitude that it's not professional to raise, and that's not a really important issue. The sick patient in front of you is what matters. And only someone who hasn't experienced that can say something like that. But also there are whole generations of minority groups that are so used to having had to go through those that they say that's just part of it, man, suck it up. And they're going to hear it from their own group, right? It'll be like an older Black physician might tell the younger Black trainee or the younger South Asian trainee, listen, this is just part of it, deal with it, like suck it up, and you know, this is not the priority here. But you're not giving the message to the community. I mean, you have those signs everywhere else in the hospital that abusive behavior will not be tolerated, but what about discriminatory behavior will not be tolerated? You know, I mean, there is something that institutions and organizations need to do at a professional level, and from the perspective of professionalism and from the perspective of patient safety, to protect these care providers, whether they're nurses, physicians, admin, PAU, whoever's working in the hospital, to not be targeted by other groups, whether they're patients or whether they're other colleagues.
Sometimes it's not even intentional, right, Naila? I mean, I recently had this conversation with a clinical group here where they asked me for the conversation because they had a racialized faculty member who had experienced racism at the hands of a patient. And rather than react to that as racism, the whole care team went inside out and backwards to reorient the entire clinic for the entire day so that that patient and that racialized clinician would not have to come into contact with one another, and without speaking to the racialized clinician about it.
Yeah.
And they all thought they were doing the right thing.
Right.
And in hindsight, had this recognition that the right thing probably would have been to say something like, we have absolute confidence in all of our providers in this clinic, and we cannot necessarily guarantee that you will get the provider of your choice. And if you are going to insist on that, it may mean that you won't get seen today until we can make the arrangements, rather than all of the workaround that they did during the day that had the provider feel marginalized even further, not just by what the patient said, but by how the team responded. Right?
And I think part of it is also, there's so many things that need to change though to make that better for the racialized physician, because now they will have to see that patient, and guess who's more likely to make that college complaint against them for not a good reason, right? So you're also, you're kind of caught between a rock and a hard place, right? Because there are just so many levels of the system that need more awareness and that need a bit of repair in how we're approaching this. You know, it's almost like someone says something that's completely, sexist, or putting down like, women doctors or whatever, someone would go up to them and say, that's just not acceptable, right? And it still happens, but someone might say, this is just not acceptable. Someone needs to have that interaction with that patient to say, this is just not acceptable, and we're going to call it out for what it is. And that might make you uncomfortable as a patient, but this behavior is not acceptable. And we will care for your illness and for what's going on here, but you need to know that what your behavior is unacceptable. And it's hard because we're not used to considering that in our interactions in the clinical setting.
Exactly.
Yeah.
Such excellent commentary. Yeah, this is so I could chime in on aspects of it, but it's certainly been an area around which, like, that's exactly the example where we hear learners raising questions, those questions being labeled as unprofessional, and the whole thing ignoring that simple fact of how do you structure, like, we have to deal with how do you structure clinical practice to deal with racism from patients in a way that is centered on the human rights and the employment rights of the racialized person who is being targeted by this behavior. Those things all come together at once there. When we could do whole modules for CBS, we could all work together and do whole modules on helping our institutions maybe navigate these things better. There's a couple more questions.
I don't want to plan out all of your sabbaticals for you, but the Canadian Medical Protective Association is another group that is starting to look at these questions in earnest, and recognizing that these complaints around professionalism, these complaints around racism from patients are going to come forward through that liability insurer. but so are the complaints around race-based medicine and race-based prescribing, right?
Oh,
And so they're
interesting.
recognizing the real medical legal liability that their member is going to be carrying if they don't figure out how to have some of these conversations. And they could probably use some help from some bioethicists, just saying.
Yeah. We've got questions about, well, just to specify that too. So we've imagined how you might deal with that with the patient. What if the patient is an elderly patient with cognitive compromise, cognitive challenges? At what point, where does the line between, you know, giving a corrective message or an educative message to the patient and what's realistic for the patient, where does that line lie, or how do we navigate that?
Yeah, I think it's a really good question. And I think every scenario is different, right? So to the extent that you recognize that it's not necessarily the patient talking, but their illness talking, then I think it's legitimate to deal with the illness for what it is. And I think a lot of racialized prescribers often, you know, to Naila's earlier point, will recognize that too. But that's not always the case. Sometimes discerning it is really difficult. And so that's part of the, you know, sort of the judgment that goes into that decision around how do you support all of the people in that environment at that time.
And I think there are some parallels to be made here with like immigrant refugee communities with trauma, because you're not correctly identifying what's going on sometimes. And I think sometimes you can have the same thing with cognitive decline and older populations, you know, and I think, you know, a lot of those biases, those ageist biases are kind of like baked into the way things work, you know? So just like how the person translating shouldn't be the focus of the clinician's attention, you'd say like the person who's there with their older, you know, grandparent or whoever, and who has the cognitive decline. Like, I think I saw a comment in there that was saying, you know, how come they're not being interacted with directly? And that happens across different populations, right? So there's similar
Yes,
issues.
you brought us to an anonymous attendee who's been waiting for some time for me to guide the conversation around to their issue, and that's exactly where we are. So what about adjacent issues of ageism, discrimination, and assumed injury discrimination? So speaking to the person with cognitive to the caregiver instead of the person with cognitive impairment, speaking to the caretaker and not the person, it's ableism here, speaking not to the person in the wheelchair, but to their quote unquote caregiver. Let's look at those connections between different forms, racism and other forms of oppression around assumptions of age and ability and so on.
Yeah, I think some of it is also the nonverbal communication, right? Because clearly, if you're talking to someone and there's cognitive decline, they're not going to be able to communicate what you need to obtain in terms of information to be able to act on, like, as information that has been given to you. But you do need to study them to figure out what's going on at other levels. And they need to feel that as a care provider, that you care about them and that you're addressing their concerns and that you care about their health. And so in a lot of ways, you can have your conversation with the care provider, but you still need to have your eye contact. You still need to have those, you know, caring, appropriate physical touch, right? Like whether you're putting a hand on someone's hand, putting some reassurance, or at the end of discussing maybe some particular detail with the care provider, turning back to the patient to say, do you have any other questions? Is there something you wanted to add? And just giving them an opportunity to be heard, even if they're not very coherent, right? So I think that speaks to a lot of the need for more humanity in the healthcare setting. And I think when you look at a higher level, when you look at the instances where you see care providers not showing the same degree of humanity that you would like, there are other systems levels issues to look at as well, right? Like physician burnout, system overload, inadequate staffing, inadequate resources, lack of work satisfaction. These are critical issues in healthcare, and it's affecting how people function, behave, communicate, and how they work. So all these issues are really tied together, and maybe it doesn't help that I'm just saying this problem is so much bigger than it looks, but it is, right? And there's so many things that we do need to address to make all of those interactions better.
I think it does help, Naila, because it points to a couple of things, at least for me, and I don't know if the person who posed the question might feel the same way. One is, what I point out to folks about systems dysfunction is that when you see the system behaving that way, it is a symptom of a system that's in distress. And often what you see is the providers at the end of that long chain of kind of distressing situations or environments, trying to control the only thing they can control at that point, which is their interaction with the patient in front of them. And so some of the control is, I'm going to speak to the caregiver because I'll get direct answers from the caregiver and it's going to take less time, or at least that's their assumption, right? And so I think it's really important to point that out, because now when I see that, I'm able to say to providers, including my own, you look like you're trying to control the patients. Have you considered that you might actually want to think about restructuring the environment so that it's less stressful and you feel like you've got more control in other places, so you don't have to feel like you need to control the patients, right? There's also something in this conversation to me that is reminding me of how desperate we are to put actual patient-centeredness back into patient-centeredness. And so much of this, kind of is about that, right? So when you see the elderly patient, the senior who has, or the older adult who has cognitive decline, recognizing that doesn't mean that you're not going to treat them for what they came in for today, for example, or you're not going to dismiss that because they may legitimately still have a sore throat or a toothache or whatever else is going on. So not making additional assumptions on a basis of the identity now of cognitive decline, as an example. And so related to that, I'm reminded by the social scientists who've taught me, and I consider Lynette to be one of them, that there's a way in which when you understand how racism in particular is constructed and how it operates, you start to see how other forms of oppression operate using similar mechanics. And so there's a way in which it's helpful to understand racism, in part because it is so visible and everybody has a strong sense of what that is. And you start to see the other things more clearly when you can do that. And I've really appreciated that as a learning.
Mm-hmm.
Mm-hmm. The next question, we have a proposal of a sort of topic, a concern that we don't often look at this area of medical practice. So physicians are involved in the Canadian immigration policy system, setting standards for medical examination of immigrants, and public health physicians, and to some extent, maybe they're responding to the political directive that comes from above, that this is supposedly what the Canadian public wants, but who is the Canadian public anyway? So the racism towards immigrants in the way that we require these sort of certificates of good health to get into the country, which could be questionable from an international human rights perspective, but it's quite common in immigration around the world. It's lessened, so in the extent that under the current government, we've opened up to allow people to be a little bit more expensive, and we still let them into the country. But even that way of thinking of people as expensive or not based on their disabilities is fundamentally ableist and has been a deep form of ableism in our immigration system. So the comment here is immigrants to Canada from regions of the global south are some of the most medically scrutinized in the immigration system. Sounds right to me. Maybe Gaynor is a public health physician. You might, we've never talked about this, but you might have some thoughts about the role of public health in immigrant screening.
And I once was the public health physician for the city of Halifax who was signing off on those immigration medicals, right? So I have a strong sense of how that system works. My new question,
Right.
having come into anti-oppression as a framing, is who gets to decide? So when I see things like that now, I'm quick to see if I can find out, and I haven't done this actually for the immigration medical process, but I'd be curious, who is represented on the policy body that has made the decisions around how the immigration medical plays out? Are there immigrant physicians on that group? Are there immigrants who have gone through the process on that policy setting group? I would wonder. It's not dissimilar to what we might do if we were looking at new tobacco guidelines in public health, and we would be looking for, to what degree is industry represented on the guideline setting body for this new guideline, right? Or the alcohol industry with respect to low risk drinking guidelines. I think we can ask those questions for all kinds of policy tables. And I would be surprised if we saw representation that actually included most of the time. I would wish to be wrong, but I'd be surprised if we saw representation that included the target populations at those policy tables. And so for me, that's the opportunity and the intervention. Is to move those policy tables away from people who actually could never be affected by them to the people who actually have to bear the impact so that they have a voice in the policy.
Yeah, and that's very much going along the lines of the way research has been restructured to include patient partners in study design for clinical research or other sorts of research. So it's not, there are some things in place that would make a good precedent or a good case going forward for interventions like that, right? So, yeah.
And speaking of learning from our social science colleagues, Eli Manning was a social work faculty member who was involved in our project as well, and brought to the table a lot of literature from the critical social sciences around the intersectionality of racialized identities, disability, refugee populations. So we have all sorts of global economic practices and resource extraction practices that lead to war and civil conflict. That's well documented, the role of resource extraction in civil conflict, creating refugee populations, directly creating injuries and disabilities, as well as, our Canadian resource extraction industries. We as Canadians, our Canadian government is extremely involved, and our Canadian economy is extremely involved in exporting those practices, which creates global populations with disabilities, with chronic medical conditions. And then we say, oh, you can't come to the country because you're too expensive. Our taxpayers don't want to cover your medical costs. Where's the justice in all this? It's, I hadn't put together those pieces of intersectionality until we were working so closely with Dr. Manning.
Yeah, and something that's very close to that issue is the issue of delayed healthcare coverage for immigrants that do make it in. So a lot of provinces have a policy of a 3-month delay. And I remember working for an advocacy group when I was a medical student in Montreal, and there were so many families, new immigrant families, dealing with trauma, depression, all these different things. And because they couldn't get a job, because the system doesn't let them get a job, and then they're depressed that they can't make money to support their family. It's our system that is making the illness, and then we're denying them care. And these are, and it's not like their tax payments get deferred for 3 months, right? So they're paying taxes for those 3 months, but they don't get healthcare for those 3 months. And so I think that's the other side of the other side of that issue, right? Is that we have these health screening policies, and then when you make it in, we still make it hard for you to get care, right? So
we made sure that you're healthier than your average settler Canadian who has citizenship, and then we won't give you care.
And then we won't give you care for 3 months.
And then we'll watch your health decline to the state of the average settler Canadian.
The average
over 5 years. Yeah.
Right. And the irony is that it costs more to the system for someone to leave themselves for 3 months because they know they don't have coverage. Whereas if they were to go earlier and get intervention earlier, they'd probably be better off and less expensive to the system. Right. So it's a sad irony.
We've got a few people who seem to be independently knowledgeable about changes people are experiencing right now, where people have TB tests out of country, but there's some increase in scrutiny. So and it could be in different jurisdictions. I don't know where the Q&As are coming from, but a couple of people are noting in their local environment that there's increasing levels of scrutiny around TB tests and vaccinations. What is this with residential visa renewals? To repeated radiation, so a radiation protection angle on those practices.
Yeah. And that is an interesting comment about the immunization issue, because we know that there are so many people who live in this country who refuse vaccination for all kinds of reasons. So it's interesting, the double standard,
Right. We're coming up towards the end of our time. Are there any last thoughts from the audience or from you, Gaynor and Naila, that you'd like to leave the CBS participants with?
I think a lot of the issues that we've discussed are sort of the areas for possible change, you know, when we look at those systemic ways in which things can change. And, you know, having more awareness and then action and speaking about the issues when they're coming up rather than keeping them down, right? So whether it's discrimination in the workplace in healthcare settings, or whether it's inadequate attention to toxins for Indigenous communities, or inadequate attention to the problem of racism rather than race in research and healthcare. I think these are all areas for research, for discussion, and people talk more about them and make a bigger stink. Then we can get the issues, you know, eventually addressed.
Yeah, I think so too. I'm really grateful for the conversation and for the questions from those who attended. I think I'm reminded by this talk, and I'm really grateful for the reminder that I guess I've embarked on an era of my career where I've decided that we don't have the world that I wish we lived in. And some of these conversations at least expose what the difference is between the world we say we want versus the world we actually have. And that gives us some choice around what actions do we take to move towards the world that we actually want. And so I'm really grateful, surprisingly, to be in that space where I feel still like we might actually be able to move towards the world that we want. And I'm recognizing how really important and impactful it is to expose that we don't have that yet. So thank you to the Canadian Bioethics Society for the conversation, because I think it helped expose it again for me and probably for your participants as well.
Yes, I agree. Thank you all so much for your thoughtful questions, and Gaynor and Lynette, always a pleasure to have these conversations. And I think just a quick comment, I know that Lynette, in preparation, there was a question there about, well, what are the new generation of clinicians? Are they, you know, kind of more protected against all of these biases? And I think the truth is that nobody is protected, because every generation of doctors comes in thinking that they're new and fresh and their ideas are not going to get stomped out, and the reality is the institutional structures are so strong that they will change that. So the only way to really change it is to keep doing what we're doing here.
Excellent. Thank you so much for those closing comments, and thank you so much for taking part in the panel. Always a pleasure, and always illuminating, and I always learn something new when we talk. And thank you to the CBS. Angel, I think you're coming on with some wrap up for the session as a whole.
Thank you so much, Lynette. Coming on with more gratitude and more thank yous. So on behalf of Canadian Bioethics Society, for our speakers and panelists, Dr. Reid, Dr. Watson-Creed, and Dr. Ramji, thank you so much for bringing your expertise and your time to today's discussion. I think it was really great, and it's a big topic, lots of big topics. And I think we've got, I'm getting some ideas for future conversation series topics we might have. And so I'm looking forward to us all continuing the conversation and continuing to do this thinking and work around racism in medicine and in education as well. So again, thank you so much. And a final thank you for everyone who joined us today. And for those of you who are not yet members of the Canadian Bioethics Society, I just want to give you a little nudge. The link there is in the chat. Andrew shared it for you if you're interested in learning more and joining the Canadian Bioethics Society. We'd love to have you. And either way, we hope to see you all at our next conversation series. So keep an eye out on your email for more information about future series events. So thank you so much, and take care, everyone.